All right, well, thank you all for coming today, and you're stuck with me twice, today and tomorrow it sounds like. Really what I wanted to do is to try to cover the aspects of treating headache care, but treat it, kind of approach it from the perspective that I take in our clinic, where we do care for a lot of folks who have Chiari malformations or who have Syringomyelia, and kind of boil down some of what we do so that it's kind of clear. It's kind of a stepwise progression for that. And I was kind of thinking about this, and I kind of came up with this video clip. And I don't know, you probably won't hear what this says, but I want to show this real quick. So this is a monkey, right? And what they're doing is they're giving one monkey a cucumber if they give them a rock. The other monkey gets grape. And watch what happens, right? So the monkey gets grape. The other one got a cucumber. They say, okay, give us a rock. Let's see what happens here. Instead of getting a grape, they get a cucumber. Throws it back. So what's that all about, right? Smart monkeys, right? And so they do it again, right? So the same exact thing. They said, okay, let's give this one a grape. Right? That one gets a grape for giving the rock. This guy says, okay. Make sure the rock works. It's a real rock. Okay, now here's the rock. Now where's my grape? Wait a minute, cucumber. Chucks it down here, right? And he goes bonkers. And what does this have to do with headache and Chiari, right? What does that have to do with what we're here to talk about? And I'll tell you what this means to me, right? We certainly respect the journey and path that people have who've had Chiari malformations, who've had surgery, who haven't had surgery but have chronic headache, people who've got spinal cord issues, and they're not treated the same as people who have migraine. They're not treated the same and shouldn't be treated the same as people who have other types of headache syndromes. There's some unique anatomy to consider, and there's some treatment options to consider that are specific to the folks who have these issues. And that's really what I'm going to spend the next 29 minutes talking about. So as an overview, if you're going to treat someone who's got persistent headache or neck pain, what do you need to consider? These are the pain-sensitive structures in the head and neck worthwhile talking about. So I don't mean to gross anyone out. It's after lunchtime. I hope no one's eating right now. But this is the lining of the brain. And it's important to know that the lining of the brain is pain sensitive. The deep gooey stuff underneath the lining of the brain, you know, the actual brain, that's not pain sensitive. You can actually press on that and squish on that all you want. If someone's partially awake in surgery, there's no pain from that. But if you irritate the lining of the brain, that's a problem. We also know that the large draining veins in the skull, ones that you're probably familiar with, like the sagittal sinus or the transverse sinus, these large draining veins are very pain sensitive also. And it turns out that the pain fibers are more dense. They're more active around these large draining veins than they are further away from the skull or from these large draining veins, which means that if you have a problem that causes buildup of pressure of these veins, if you have a problem that causes distortion of these veins or manual pressure on the veins themselves, that can all generate pain or irritation for people, and that's different than what we expect to see in things like plain migraine. Then you got the nerves themselves. These nerves bring all the pain from the skull and the soft gooey stuff around the skull back into the skull. And even the scalp. The scalp is pain sensitive and has fibers that contribute to the same areas of the brain that respond to headache. So the scalp itself is part of headache. And all the vascular structures underneath are also included too. And the other anatomy slide I want to show you real quick is this idea of looking at the trigeminal nerves. And those who are kind of new to this concept know that trigeminal nerves are brought up every now and then when we talk about migraine or we talk about headache, but they should also be considered as to what their role plays for those who've got headache from cerebral spinal fluid problems or for people who've got Chiari malformations. So the trigeminal nerves make bundles that go to the lining of the brain. The trigeminal nerves, these yellow things on this picture, bring the nerves back to the brain stem itself, which is what helps process and coordinate pain. But here's the next thing, is that these nerves also go down the spinal cord and come out the back of the head. So it really makes a webbing of pain sensation around the skull, so that any pain or irritation that affects the head causing headache is going to come through these trigeminal nerves in one way or another. And really, that's an important aspect, because when you look at helping people who've got really intractable chronic headache from a CSF issue, you want to consider what you can do to these nerves to make the pain less sensitive and make them more functional and make them feel much better. So our job in our headache clinic is taking this over-irritated system and getting it to calm down. And we've got some good ways of doing that. But there's a few more uniqueness things to think about. This is kind of a cool picture. I don't want to bore you with a lot of medical focused research, but it turns out that if you take an electrode and you stab someone in a polite, nice way, stab someone in the back of the head, right at where the neck and head come together, right? This thing we call the occipital lantal junction, right where the C1 nerve root is, and you provide an electrical stimulation to that nerve root. Some people get pain in the back of their head, but some people get pain referred to the front of the head. And this study showed 10, I don't know how they got people to volunteer for this, but 10 volunteers. And they actually stabbed in the back with an electrode. And they found that 7 out of the 10 got pain around the eyeball. 3 out of 10 got pain in the back of the head. I was not one of these people. I did not sign up for this. But the cool thing about this is if someone's prone to have migraine, if someone in their life history had episodic migraine on a regular basis, they're the dudes and dudettes who got the pain around the eyeballs. And the people who are not prone to have migraine in the first place, they get pain in the back of the head. So if you think about this, you've got a mechanical structure issue with those who've got Chiari malformation, who are going to have a pressure issue affecting the specific sensitive area, but their pain can be referred to many different spots. And that's confusing to us nerds in the headache clinic. Sometimes we don't really think of it that way, but really pain can be referred from an area in the back of the skull all the way to the front, and that's an important aspect for us. A couple of the cool things about anatomy. This is a picture of the occipital nerves. Who here's ever heard of the occipital nerves before? 50-50. All right. I'm going to assume the other people who didn't raise their hand either aren't paying attention or don't know about it. But the occipital nerve is a nerve that provides the scalp sensation to the back of the head, right? And so if you ever were to numb that with an injection, people get numb in the back of their head. The rest of the head stays normal usually. But the thing about this nerve is it's got some unique anatomy to it. It's a long spaghetti-like nerve. It leaves between the first and second bone of the top of the neck, and it provides sensation to the back of the head, but it also provides pain sensation to the posterior fossa for some people. So does that C1 nerve root. It also provides connections to nerves in the rest of the body. And this nerve gets irritated if you extend the head or flex the head like in a car accident or physical assault, but it also can be irritated from surgery. So for those who've had surgery in the back of the skull, surgery to get to those areas, and the excellent surgeons do their best job to take care of all the tissue they go through, but invariably a small branch of this is going to get irritated or severed in some of the surgeries that are done. And indeed, this can be a source of pain. And even if this nerve is completely intact, its job is to respond to sensitivity of the tissues around the back of the skull and scalp. So this is commonly involved for those who've got chronic headache, either if they've had surgery from Chiari malformations, or if they've had no surgery but got compression in these structures. It's a very common road path for us, and it's a way to help people, and I'll talk about that in a minute. Is there a question there? No. I'm open to questions too. So cervical facet pain, one other thing to think about is that if you look at the neck structures, there's these things in the side of the neck called facets. And if you don't know what those are, but you know friends who can crack their neck, and they kind of look away and it cracks. I can't do it myself, so I can't give you an example of that. But I can assure you it only cracks 6 times. You know why it only cracks 6 times? Up to 6 times. Because there's only 6 real facets out there. If you count them in the neck, there's 6 facets that can crack, and that's what people are doing. Now, these joints in the side of the neck are fluid-filled joints just like our finger joints. So if you irritate them, either from trauma like car accident, physical assault, whiplash injury, or if they get irritated because of overwork after surgery or healing after having manual therapies to it, that can generate or stimulate persistent pain in people. And that presents another opportunity to help people with chronic headache, especially if they've got structural anatomy variances in the top of the neck or head. People who've required fusions, cervical fusions to help their spine issues, and I'll get you in just one second. Oh yeah, agreeing. Oh, whew. One person in the room agrees. That's good. I hope more at the end of our discussion will agree. But so it turns out if someone has a fusion, let's say someone's had a fusion at C3 or C4, that stops that segment of the neck from moving. However, if you're still going to do normal daily activity, look left or right before you cross the street, whatever you're going to be doing with your life, you're going to have to move your head somehow. So you start overworking areas above and below. So you can certainly develop irritation in these neck structures after surgical fusion just because of how our neck operates. And it's important for us in the pain world to appreciate that because there's opportunities to help people based on that concept. So one other thing that we see common in folks who've got Chiari malformations is this concept of hypermobility. And I've got this picture over here. This is actually how you test people for peripheral joint hypermobility. This is called the Bite and Flexibility Scale. But it turns out folks who've got Chiari malformations are more prone to be more flexible than other people are. And that by itself is kind of cool to know, neat party trick. But there's some important health aspects attached to that too. Let me show you this. This is a patient of mine. Her name is Kelly. I did get her permission before I took her picture. I just got it signed, thank goodness. But she can move her neck pretty funky. She can rotate her head with ease beyond 90 degrees. For those who are familiar with the movie The Exorcist, it looks similar to that. She can pull her fingers back simply without any pressure at all. It goes well beyond 90 degrees, which is a cutoff point for scoring this stuff. Her thumb touched the wrist really easily too. And she's got a hypermobility issue of her high neck. And the reason why I bring this up too is because you can get a syrinx part of hypermobility and you can get Tarlov cysts. Who's ever heard of Tarlov cysts besides the surgeons in the room? Okay, good. So Tarlov cysts, these things are thought to be really normal kind of things by themselves. If you have just one Tarlov cyst, that's no big deal. What it is as the nerves leave the spinal cord and they go to the rest of the body, they're surrounded by a lining and that can pick up fluid and it can make a little ball of fluid for some people. Just one of them is no big deal. If you have multiple ones, like these pictures show, it's really suggestive of hypermobility. And the point I'm trying to make here is that people with hypermobility have some flexibility issues with the lining of their spinal cord that make them prone to have CSF problems, CSF flow problems. Sometimes these pockets of fluid leak, and people get low pressure headache syndrome from that. And sometimes they don't leak, they just expand and contract. So people have varying pressures of the fluid in their spinal cord, and that generates all kinds of persistent headache. Here's just a picture of some more hypermobility stuff, and that spinal needle over there is to threaten you that sometimes we look at opening pressures to decide how much fluid someone has, but we don't do that frequently. If we're curious about someone having too low of pressure causing daily headache, we do this. Now, this person was not a paid model, nor is this a patient of mine. This happens to be our receptionist. She doesn't work for us anymore. I don't know what happened there. I don't know if it's because I said, hey, I want you to lay flat for 10 minutes in this position. But this is how we test for a low pressure headache syndrome, because people who've got garden variety plain migraine hate this position. You know, leave them there for 15 minutes, and by the time you come back, if you answered a phone call or whatnot, they've already written 2 angry letters to your chairman. So they hate that position. So if we put someone in this position and say, you know what, my headache's worse, why'd you do that to me? Then I'm not so concerned about low pressure headache so much. Now here's the flip side. Let's say someone says, you know what? My headache's better. My daily headache, the headache I have almost every single day, is actually improved in this position. We think of 2 things. We think of low pressure. We also think of people who have a neck issue, because in this position you can mechanically take off some pressure at the top of your neck. So this is something we check for sometimes to see if someone's got a pressure issue, a low pressure issue, or to see if someone's got a neck issue sometimes. Now, Dr. Buparaj knows far more about this than I do. I'm just going to show you if someone does have chronic low pressure, this is what their brain MRI looks like. And what doesn't belong in this picture is that white rim around the brain. That means that there's so much low pressure and there's a space issue where the brain kind of should be floating and it's not floating as much. The lining of the brain expands. It actually gets blood vessel engorgement to take up that space. And that's when you squirt the dye in someone that lines the brain, that's what that looks like. And you can get a Chiari appearance to this. So if you looked at that top picture, the top picture in this photograph, you'd say, oh my gosh, this person's got a Chiari malformation, check that out. And you can see on this picture, I won't let Dr. Buparaj correct me on this one, but I'm just going to slaughter it for a bit. They've got a flattened lump in the front of their brain. That's this area right here. That's not a medical term, by the way, but this gets flattened. The cerebellar tonsils are lower than they're supposed to be. And there's a few other subtle findings with this. But here's the same exact patient underneath. And that picture looks much better. So what do you think they did to fix this person who came in with low pressure headache and it looked like they had a Chiari malformation? What do you think they did? Oh, great. So you've been paying attention. You actually listened the last couple minutes. So I would like to say we put her in that funny position. She got fixed. That's not what was happened in this situation. But great idea. What's that? Now that would be even better. That would probably do it too. No, this person actually had one of those blood patches, and that's where they take blood and they actually put it in the low back to build up pressure. So people who've got CSF leaks from hypermobility, who have an appearance of a Chiari malformation but really have a low pressure issue, actually are helped by that. And actually it makes the brain look different on the MRI. So the other thing, they're going to have an awesome lecture from Dr. Lieber coming up in a little bit. And he and I talked a bit. He said, leave migraine to me. He's great at covering a migraine, so I'll do that. But we talk about orthostatic intolerance in migraine because this is something that's comorbid, meaning it occurs more likely for those who've got migraine or chronic headache than people who don't. If you couple that with people who are more flexible than they're supposed to be, they're far more likely to have this than other people. And this means that if someone is asked to stand up quickly, they're more likely to faint. They're more likely to feel lightheaded or dizzy upon certain positional things. And if you look at just plain migraine folks, they faint more than other people do in general, more than normal folks. But if you look at people who've got hypermobility and chronic headache, they faint even more than those people do. There's this thing out there called Positional Orthostatic Tachycardia Syndrome, POTS syndrome. We're not very creative about naming things in the medical field, just kind of put a bunch of letters together and then call it something. But these folks actually have variations of how their blood pressure works and how their heart rate works. So they overshoot. So sometimes their heart rate goes too fast. Sometimes their blood pressure drops too low and they feel really sick from this. And you can see this also in people who've got hypermobility and people who've got autonomic dysfunction. The deal with Chiari malformations is that can affect some of the autonomic, some of the nerve back feed that you get when your brain changes position in space. People who've got a posterior fossa problem in the back of their brain can get irritation of these sequences. And so they're more prone to have autonomic dysfunction, more prone to have fainting, more prone to have a difficulty maintaining their blood flow. And this is what they kind of look like. If someone has advanced autonomic dysfunction, their whole body responds to this stuff. So they get constriction of blood vessels when they're not supposed to, and their hands get blue or white. And there's ways you can help this. Last thing, and this is just proving if we don't name things the right way, this person's got something wrong with their ear. This is the same person. One ear is regular color, the other one's red. This one's got an autonomic problem with his ear, so much so that he can't regulate the temperature of ear. We see this with migraine with autonomic dysfunction. That's just called red ear syndrome. And I threw that in there just to prove you we don't name things the right thing. What kind of name is that, you know? So one other thing, what happens if you do something dumb to your neck and you've got pain sensitivity in those areas? Don't do this at home. Yeah. So this does happen to folks in neck extension, neck flexion injuries here in slow motion. That's a big deal. But I bring this up just to kind of talk about the muscles in the back of the neck and head. So check this out. This is actually a cartoon type picture that shows muscles as they connect right at the top of the neck and head. So I've got the C1 bone that's kind of been cut away in this picture. It's kind of hard to see, but I'm going to show it to you anyways with my arrow. So see that right there? That's the bone. That's the C1 bone cut away. Here's the spinal cord. And right here's where the skull's supposed to be if they actually drew the picture of it. And what I'm showing is these muscles. You got tiny little muscles. These guys that go from one area of the bone in the spine to the other. And here's the thing. If you look in anatomy textbooks, the same anatomy textbooks we all looked at in medical school and those things, they show that these muscles are very separate, that they're just one muscle from one part of the bone to another part of the bone. And when they squeeze together, it makes those bones get closer. That's what they tell you. But the key is these small muscles, the ones that are close into the neck and head, right where the neck and head come together, they're connected to each other and they're also attached to the cervical lining of the spinal cord so that you can get attachments. And if they get spasmed or irritated, either because of constant pain from the C1-2 nerve roots that we talked about or from trauma, they actually get spasmed and they pull and they yank. So a lot of the Chiari folks I've cared for describe a pulling sensation, almost like they got a constant ponytail squeezing in the back of their head. And when you ask them to move their neck, they look funny. Check this out. So I'm asking her to take her chin down to her chest. This is what she can do. So she gets just about that far, and that's about as far as she goes. Now you have to look all the way up to the ceiling. She goes as far as she can, and then she kind of ratchets her head when she gets up there. And this is all signs that her muscles are far too tight in the back of her head or neck. Right? And this is a problem, but you can help these folks with getting those muscles to relax. And we do that in a couple different ways. And I'll show you what we do. So if you're going to help someone, this is what you want to do. Don't be this guy. Bring up the rings, please. My favorite part about this is what the priest does at the end. Watch this devil look he gives him at the end, right? You know you're in big trouble when your priest glares at you like that. And when I bring this picture up because how you help people makes a lasting impression, right? And and I say this in a good way and a bad way. And a bad way is that we've seen folks who've had Chiari issues and they come to our clinic and they say they called me migraine. They put me on these migraine medicines and it didn't really help me. And really we were frustrated because they were told that their Chiari may not be part of their headache or that their surgery may not be part of why they have daily headache still. And that is not always the case. The other thing is, we gap this up in our clinic sometimes too. But if you help someone with the right tools, they can do fantastic. So first thing, there's a couple of vitamin supplements that are very effective to reduce lining of the brain irritation, as well as to reduce muscle tone. So for people who've got really tight neck muscles, people who've got some irritation who don't want to be on prescription tablets or whatnot, these are the vitamins worthwhile talking about. There's magnesium glycinate or oxide, both of which work on this pain receptor that reduces pain. It's got a fancy name to it that we call the NMDA receptor. There's a vitamin supplement called boswellia, and boswellia is a root extract. The Swahili name gives it away. It's from South Africa. But this is an anti-inflammatory supplement that works kind of like ibuprofen, kind of like naproxen, but it doesn't have the GI irritation that we've seen in studies. So it can be very effective for some people. And then Butterbur is in there, and we don't use a whole lot because if you use the wrong brand of Butterbur, there's a slight risk of having kidney issues from it. But by itself, it can be pretty effective if you get the one that's been specially prepared to not cause that issue. Other thing is we use quercetin in our clinic, and quercetin is a grapeseed derivative. Quercetin is an antihistamine type therapy. And so this can be effective for some people, especially if they got some inflammatory component to their chronic headache issue. There are some tablets to be aware of, and there's some tablets that don't work well for plain episodic migraine, but can be very effective for people who've got neck-related structures or irritation of the lining of the brain. I got some of these guys listed, but let me actually circle a couple of worthwhile mention. So I've got in here something called tricyclic medicines. I've got things on here called Topiramate and Pregabalin. I'm just checking my time. I don't want to go over here. So Topiramate, who's here to Topiramate? Anybody? I'm kind of surprised. We got 4 hands, mine included. Let's call it 5. Oh, 6, we'll call you 2. But that's not a whole lot. And Topiramate is one of the most commonly prescribed medications by us neurology types to treat daily headache. The cool thing with Topiramate is there's not a whole lot of side effects. I listed some of them, but most of these go away if you stop the medication. But it can be very effective. This medication doesn't seem to discern where your headache's coming from. So if it's related to a posterior fossa issue, if it's related to the back of the skull being irritated, or if it's from migraine, it still seems to help. And this is something commonly prescribed by neurologists or primary care physicians or other physicians to treat daily headache for people. It's also famous because it causes weight loss in people. So if I'm talking to young folks and I say, well, it's going to do these things here, but it can cause weight loss, they don't listen to anything else I say. They kind of sign up sometimes. So just to be aware of that. The other one's Pregabalin, also known as Lyrica. And I should also include gabapentin and Neurontin. It's quite similar. They're both similar to these medications. And the thing about these medicines is they've been studied about 10 different times for migraine prevention, and they don't work. No, they've tried them so many times. They were desperate for these medicines to work for migraine, but they never showed in any studies that they were effective for migraine prevention. However, the rules change. If someone has an irritation of the lining of the brain, an irritation with their neck structures, gabapentin, Neurontin, Lyrica, which is known as Pregabalin, can be quite effective. What's cool about this is there's some sleep improvement with this too. We know that if someone has daily headache, sleep is paramount. You got to get someone to sleep well if you want them to get better from headache. And these medicines don't knock you out. It's not like you take a pill, snuggle up, and you're out. It's the kind of thing that if you take this medication and you awaken in the morning, you say, I just feel more refreshed or more like I got high quality sleep. And people with daily headache have really poor quality of sleep in the first place. So anything we can do can help that. So a couple other medications. There's Nortriptyline, also known as Pamelor. Who's heard of this one? Anybody? All right, so wait a minute. Hold on a second. Everyone's got their hand up for that, and there was like 6 people for the other one.
What is the name, the general name?
Topamax is the other one? Oh, okay. Who's heard of Topamax then? All right. I don't want to go off on too much of a tangent, but one thing to know about, if you were a previous responder of Topamax, which is the brand name flavor, went generic in 2007, and you haven't done well since 2007, we encourage most of our folks to try to go back to name brand, or we have them go to a different type of generic. Who wants to take a guess how many generic types of Topamax are out there in this country right now? 120? Okay, keep that number. If we're playing prices right, we're going to keep that number out there. Who wants to take another? You're a bit high, sir. 10. Okay, so you're there. One more number? 20 and 17. So for playing the prices right, you would win. You go to the Showcase Showdown because the number is 37. 37 different generic manufacturers. You, sir, overbid, so you get the wah, wah, wah sign. And then everyone else is sticking around for the questions, right? But the deal about this is why it's important, because in this country, to be considered generic, you just have to have your chemical structure, how it looks under the microscope, look between 80% and 125% of the standard molecule. And things like Topamax are very hard to manufacture, a bunch of different steps to it. So sometimes when they use one different manufacturing process compared to another, it becomes a little bit less effective. So I've had some people who've done so well on Topamax that I don't get it, Wade. It was great until about 2008, and then it just stopped working. And I said, I think I know what your issue is, and go arm wrestle your pharmacist for a brand name. Anyway, I digress. So brand name, Nortriptyline or Pamelor, this is actually a very effective medication for some people. It's generic. It's not super expensive. A lot of people have tried this medication. There's side effects, though. People get dry mouth. Sometimes people get lightheaded on this medication. It can cause fatigue in the morning. But it is pretty effective. We typically prefer this one over amitriptyline, which is known as Elavil, only because this one seems to be better tolerated by our folks who've got more sensitive nervous systems, but that's certainly just anecdotal. How about non-tablet therapies? What else can you do? Well, sometimes you do trigger point injections. And this is where you take numbing medicine, the same kind of sauce that a dentist uses before a dental procedure, and you actually put it underneath the skin on those muscles I was talking about. So you can do really, really quick muscle injections. It usually doesn't hurt really bad. It stings for a millisecond, but then it goes away. And what that does is makes those muscles move up better and reduces some of the muscle pain to those guys. Botulinum toxin, which you may be familiar with as Botox, is also a treatment option for daily headache. It does work well for some of our folks who have a Chiari issue. It's not the same Botox as you're familiar with from LA or from California, land of fruits and nuts. This is a concept of taking nerve-to-nerve pain transmission, making it less sensitive. The downside on this is that you got to get it done every 3 months, no matter what. This does not affect facial expression. So the people who get this do not look any different, good or bad. Interestingly, I get far more complaints about people worried it's going to make them look funny than I get people saying, I want to look younger with it. But this doesn't do either one of those things. So, if you look funny, it's not because of the Botox. All right. So how about something called an occipital nerve block? And I spent the first couple minutes of our discussion talking about that nerve in the back of the head. There's something called an occipital nerve block. And this is where you take the same type of numbing medicine, plus or minus some additives in there, and you actually put it underneath the skin. And I got to tell you, this is a really, really safe thing to do. And I know you guys are looking like I'm crazy. What the heck are you talking about? That's what I thought when I first heard about it. But you know what? It is incredibly safe. So it's not like this picture where you would hurt somebody. This is just a scalp injection. And to do this, you just have someone sit in a chair. They put their head on something. They lean forward. By the way, this guy used to work with us too, and he doesn't anymore. And I'm wondering if there's a theme here or not, but you start feeling in the right spot. Everyone has this. Everyone in the back of their skull's got a little notch called the occipital notch, some more profound than others, but that's where that nerve lives. And all you want to do is put medicine just above that in the scalp. It's only 3 to 5 millimeters underneath the skin surface where you put your medication. It's really, really safe. Even surgeons can do this. All right, and this is what it looks like. So I got this guy, let me take a video. This is not someone who works with me. It's just an injection. I hope this doesn't make you feel lightheaded. But you just feel the right spot. Tell a dumb joke while you do this. That's what we always do. It's required. And then you poke them in the back of the scalp. Hope this doesn't bug you guys. Yep. You squirt in your medicine. You're going to watch this excellent physician do this. This is me doing this. And that's it. And you're all done, right? I'm doing really slow for the video, but this goes quicker than this. And then, what's that? So it doesn't hurt me at all. Oh, the patient? Oh, yeah. So what I tell people is that the pin poke actually is really not uncomfortable, right? And I'm serious on that. Most people can't tell when the pin goes in even because the nerves are very forgiving back there. The medicine itself, what we use in our clinic is something called bupivacaine. Bupivacaine is acidic by nature. So our bodies, when we put it underneath the skin, you've got to switch it over from an acidic medicine to our normal pH. So that's what stings. So about 5 seconds of, hey, that kind of stings, and then it goes away. But after that, there's no pain with this, right? And what people experience is a numbness sensation up the back of their scalp. That numbness lasts maybe 4 or 5 hours, and then it goes away. The numbness is always temporary. You can't make it permanent ever. I've never seen that in my lifetime. And then the headache relief, on average, is 4 to 6 weeks. So what this is doing is it's calming that irritated nerve circuit that we talked about earlier, taking away that stimulus, and however long it takes your nervous system to rev back up is your pain benefit. So I've got some folks in my clinic who all we do is an occipital nerve block every 3 months or so, and we high-five each other, and And that's it. They're on no daily tablets. They have really rare breakthrough headache episodes, and it becomes an option for people, and there's no side effects, no risk to this. It's the same risk as when a dentist numbs your tooth. So, to me, it's a very clean, easy thing to do. I talked a bit about this before, and I'm out of time, so I'm just going to buzz through the stuff real quick. Shamana Ramana. Stimulators aren't a big deal for this scenario anyways. And conclusions. Okay, so what am I trying to tell you with this discussion? First of all, the back of the head is sensitive, and it can generate headache. It can generate headache wherever the heck it wants. Front of the head, back of the head, side of the head. It can all come from the back of the head and neck, right? Cervicogenic headache is the fancy name we get for people who have neck-related headache disorders. Some structure in the neck causing headache, and you treat those folks different than you do plain migraine. That's an important issue. People who've got neck-related headaches can look like other headache subtypes, so they get called migraine, they get called cluster headache, they get called hemicranial continuum all the time, and it wouldn't be a big deal. I don't really care what people call it. I just want people to get better. And the problem is some of the treatments we do for folks is limited based on what we think their headache is from, and that's where I'm trying to get patients and physicians to be aware of different aspects of that. And then the other thing is there's some simple things you can do. There's some supplements that we mentioned. There's a couple of tablet medications. There's plenty more that I didn't have time to go into, but just as an overview. But there's also some interventional treatments, either trigger point injections or occipital nerve blocks that can be really effective for people and have almost no risk to them. So with that, you can be like the surfer guy and surf through some rapid waters and actually make it to the other side. Thank you very much.